or why can't you just walk more and eat less? When we really begin thinking about what happened to you instead, it begins to make more sense. And we can really begin to look at those root causes and those underlying factors. And that's what this ACE pyramid does, is it helps us begin to understand that progression. As I said, partners became interested and invested at the state level between education, corrections, health and human services. Our collective goal is to really analyze this data, share it across our systems, leverage resources, develop communication tools, and then help communities like Ottawa expand to have county and regional data. So we started to do that. We have at the state level, we had a training last year where we pulled together 60 partners from corrections, from health and human services, and from education. And we took 3 days to take a deep dive into the content, and that research has been shared. So I'm happy to share that with anyone who may work with folks in education, corrections, or health and human services. There are 60 of us. We call ourselves thought partners to kind of begin to think about how we're going to change program policies and systems. We also need to share the data across systems and understand and respect the unique needs and perspectives. So in Ottawa County, you're lucky to have this local data, but there are many communities that don't have it, and so beginning to understand how to help them do that. And then the last thing I wanted to share with you is that I'm part of the Michigan ACE Initiative. The Michigan ACE Initiative is separate from my work at the department. It's an initiative that was funded in December of 2016 by the Michigan Health Endowment Fund, and one of the biggest things they did was create a corps of master trainers, of which I'm one. There are 126 master trainers, and that's what these little dots represent on the map, and you can see they're all around the state, and I think that's one of the biggest resources that we can leverage in communities. So while I sit in Lansing at the state level and I'm happy to come talk to communities, there are master trainers throughout the state. And so if you go to miace.org, which is listed there, you can actually see all of the master trainers. And so I encourage folks to know who their master trainers are, to be able to get information like this shared. We're creating user-friendly information tools. I encourage folks, if they haven't, to see the film Resilience or the TED Talk that was done by Nadine Burke-Harris. I'm happy to share these slides so we can share these links with folks. And luckily, in 2019, we're asking these ACEs questions of the entire BRFS sample. So in 2020, we'll be able to look at prevalence by county across the state. So all counties will be able to look at where the prevalence is so that we can begin to look at where those pockets of high ACEs are. This is one of the last slides I'll share. This was a huge aha for me. When I went through that guiding near training, we were trained by a expert from Washington State, and this is actually a picture of Washington State. So on the left-hand side, those counties that are shaded red had the highest ACE prevalence. They did this ACEs data through their BRFS for a number of years, and they were able to determine where the highest prevalence was. So in Michigan, we might be able to hypothesize about that, but we don't currently have that data. And I remember when Laura put this slide up, she said once we had that county level data, we were able to compare it to all kinds of other data. So on the right-hand side, the same communities that are dark red are also light yellow, and those are communities that had physician scarcity, the highest levels of physician scarcity. And what that means then is those communities that had the highest ACE prevalence also had the fewest number of physicians or medical homes available. And when you have that data, it becomes empowering then to help communities and help decision makers actually make decisions that are driven by that data. So one of the things that we're going to continue to talk about is that there is hope. There are things that do buffer ACEs. They're known as resilience factors. So those are some of the questions we're asking as well on the BRFS, and have data that was just released 2 weeks ago that are showing that rates of ACEs go down when these support factors are in place. And the last slide I'll share, because I'm way out of time, is this PAR graph. This stands for Population Attributable Risk Graph. So this is a pie graph looking at negative health outcomes. You could look at any number of them, but this is mostly chronic disease outcomes, and it comes from Washington State. And the black oil slick or blob in the center of it are those that are contributed to ACEs. So if you look at cardiovascular disease, you can see that just over 25% of cardiovascular disease is contributed to ACEs. or early trauma. And you can see that for all of them, even cancer and separation or divorce, anxiety, they all have this origin or a huge origin in ACEs. To me, the message of hope is in things like tonight. When we all come together and talk about this, we can become the sponge in the center of this oil slick, and we can collectively work across all these sectors and across all these health outcomes to shrink the ACE attributable effects. So my hope is that when my kids have kids, that oil slick that may be present in Michigan will be far less, because we've come together as communities and across sectors to address the negative outcomes and support resilience. With that, I'll turn it over to the next presenter.
Thank you. Angela May.
Good evening. So I am Angela May. I'm a pediatrician at North Ottawa, and I started in January, so I haven't been there very long, but I've been involved in a couple of opportunities to get involved in the community here as it relates to ACEs. I've enjoyed it so far. I do have a background in child abuse and neglect, and so some of this was very much what I was doing on a daily basis when I was in my last role. And so I've been in a couple different settings where ACEs are taking shape in front of me, and tonight what I really wanted to focus on is what that looks like, and from the perspective of a medical practice, how this is all experienced by medical staff, by people who are interacting directly with families in a medical setting. And so this is such an important topic. I'm very excited that this is being talked about like this, because when I was seeing children who were suspected of being abused and neglected, I was seeing it in a very intense way. I mean, I was seeing the end result of all these ACEs, and there was a sense, even before I really got into the idea of ACEs, there was a sense that there had to be a way to intervene quicker. There's always that burning sensation to try to intervene or do better, or what can we do for this child? Because by that time, a lot of times they're in foster care. They're already quite far gone, and so then you're picking up the pieces, and then pretty much it's a given, even though you want to have as much hope as possible for each individual child. It's a given that they're probably going to experience some of the adverse outcomes of the ACEs that they've been through. So then, moving over to the primary care world again, so I made a shift in my career. I enjoyed child abuse and neglect, but for a variety of reasons, it was most in my heart to be in primary care, and so I moved over to that setting. And then, of course, you're not seeing as many clear indicators that these children are going through ACEs, but you know that the seeds are still there. And so there's a number of approaches that I personally take to try to plug into the ACEs that are going on in my families. But then also from a systems approach, I think our office is doing pretty well at looking at as many factors as we can, identify in a systematic way. I'll take you through some of those. There's always room for improvement. Definitely have some things in mind as I sit through these talks, ways that we can do better. So I guess to start with, thinking about ACEs from the well child standpoint. When I see a child, when I see a family, usually it's a child, parent, they're coming in, and there's a lot of great work that can be done right there. Communication with their provider. I think that's essential. So I really try to make sure there's a complete open communication. But I know that families hold their cards close, and so you also need tools to try to get them to open up a little bit. And so from the very beginning, when we have a mom with a 2-week-old baby, we're looking at her postpartum risk. So we know that postpartum depression is one of those mental illnesses that can exist in the home very early on, and can make a huge impact on the life of that newborn and any siblings they may have. So From the very beginning, we're doing depression screens. We do one at 2 weeks of age, when the baby is 2 weeks of age. We do one at 1 month of age, at 2 months of age. And so we're trying to follow that out and make sure that we're picking up on postpartum depression in the parent. And then, as that baby grows, we're looking at development. And so one of the things that we know about neglect is that it can affect the development trajectory of a child. And so when we're identifying deficits in a child's neglect, or in a child's development, if there's a significant deficit, of course, one of the things we're thinking about is, okay, where is this coming from? Is this coming from, is some sort of medical problem with the child? But always in the back of our mind is that emotional neglect can present itself as a developmental delay, usually global. You'll see it in language development. You'll see it in physical development. You'll see it in fine motor. You'll see it in social development and problem solving. So if we're seeing kind of a broad sweeping delay in development, that'll be one of the things that gets assessed for in that visit. And so it's got a interwoven feel to it. It's got it's broad and sometimes overwhelming in the sense that when we're looking for ACEs in the primary care setting, there has to be radar up at every touch point with these families. And we don't want it to color completely our interaction. I don't want it to color completely my interaction with family. I don't want to be always looking for problems, but in some ways that's my job. And it helps later on for me to understand that family, for me to help them through any ACEs that we really do identify. And so part of looking at sexual abuse, physical abuse risk for these families would be just, getting, especially when the child is a little bit older, it's all physical exam based when they're younger. If you find something, you can ask follow-up questions, can refer to a specialist. I wouldn't take that on myself now. That's not my role. Refer to a specialist in child abuse and neglect if I needed to. But as the children get older, they're 11, they're 12, separating them out from the parent and making sure that I'm developing a bond with them directly, letting them express any concerns that are on their mind. Are they going to come out and make a disclosure in that setting? You don't know unless the opportunity is given, so that would be another opportunity. And then, so some of the other things, divorce, we know that when there's a family going through divorce, we touch base on that in our conversation. And there's much that